All. This is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So, you know that I always have rock stars with us. Today, we have another rock star with us, and his special association with the topics at hand that we've been discussing, that is COVID. He is a researcher for virology, immunology, cancer therapy. So let me very quickly. So his name is distinguished. He is distinguished Professor William Murphy. You actually have seen one of his papers. So let me just quickly show you the paper. Here is the paper that you have seen me present in the past. So we would talk about this paper. This is the autoimmune disease after the COVID infection or vaccine. So we'll talk about this and more. First of all, let me just very quickly introduce, welcome, Dr. Murphy. Thank you very much for being with us.
Thank you very much. It's a pleasure to be here. Please, Bill Murphy. Yeah,
So very quickly,
go ahead.
if I can very quickly show your biography. So, cool beans, this is Dr. Murphy's biography. This is his papers, his work. So, just a few of the papers. So, look at this: natural killer cells. So, before even that, Dr. Murphy is the distinguished professor, departments of dermatology and internal medicine, hematology and oncology, University of California, Davis. He's also the vice chair for research departments of dermatology and internal medicine. And look at some of his papers here, some of his work here. Can you see this? Impact of aging and obesity on immunotherapy, immunotherapy impact on immune function, hematopoietic stem cell transplantation, graft versus host disease, which is a hugely important topic, natural killer cell subsets, NK as immunoregulatory cells and anti-tumor effectors, and so much more. So once again, Dr. Murphy, welcome. Thank you very much for being with us. Tell us a little bit about yourself.
Well, thank you. So, my doctorate's in immunology. I've been doing this for over 35 years. My primary emphasis, I was at the National Cancer Institute for 12 years. And there I was director of basic research at an NCI up in Frederick. And our emphasis has always been looking at the way to use the immune system to fight cancer, but then realizing too, there's a lot of parallels between how the immune system fights cancer versus how it also fights viruses. So we were actually some of the same pathways. So my work has been primarily involved in preclinical, or what we call translational research, where we're interested in not only on how we can use the immune system, which those of you that have been following the medical field, cancer immunotherapy has exploded because of recent successes, but then also because of the pandemic, understanding the immune system, how it's regulated. So my lab has been for the past, for many years now, looking at how we do basic research modeling. The primary cornerstone for all immune research has been the laboratory mouse, which is genetically identical. But as we know, there's big differences between mouse and man. And so we've been trying to understand how we can use these preclinical models to then better anticipate what may work in people. And so the whole concept of translational research is called bench to bedside, back to bench, which means so the discoveries that we make are applied, but then we learn and we go back to the model and try to make it better. So our lab right now has been looking at the impact of obesity and aging on the immune system. We're realizing now there's a huge impact, and given the population demographics, it's particularly relevant. But we're also looking at ways that we can understand how the T cells and the NK cells, the immune arm, sustain themselves, because obviously with cancer, you want a sustained response. If with virus, you want a sustained response. So the thinking now is understanding long term. So what we found is a lot of prior therapies, what we call short-term gain, long-term loss. We see the initial effect, but then the immune system contracts and we lose the effect. And so we're trying to understand some of those ramifications. So that's my research lab at UC Davis right now.
Awesome. Thank you very much. So we have, please don't mind my expression, we have the king of immunology with us today. I have
Really?
been talking about immunology and dazzling our Cool Beans group about immunology. And here we have somebody who is actually a PhD in these areas. So thank you very much once again for being with us. I also want to very quickly show to the cool beans this paper. I had actually discussed this paper a few days ago. So my request, the very first topic, please tell us a little more about this. So this is anti-idiotype antibodies in SARS-CoV-2 infection or vaccines. I'm going to present a case to you, and then maybe have that case as a reason to have this discussion. There are some folks who are long haulers or may have a post-vaccine injury, and what happens is they continue to relapse.
Mhm.
They become better, then they relapse again, sometimes because of some stressor or sometimes just by itself. Is
Right.
there any role of this research that you did? Is there any overlap here?
Yeah, I mean, I think what we know now is the immune system is dynamic. In other words, think of it like ripples in a pond, where you throw a rock in, whether it's the initial virus, and it's going to have a cascading effect. But it's not isolated. There's going to be your experience from other infections, or you're going to be exposed to other things, and that's going to cause ripples, and then they're going to have effects as well. Add to that when you have stressors. Stress has been known to be immunosuppressive, but it's going to allow, therefore, there are certain immune cells that are immunosuppressive as well, but you're going to see a dynamic effect on the effect of different antigens, different exposures, and therefore also as we get older, certain pathways no longer work as well. If we become obese, certain pathways no longer work as well. It's called inflammaging. And so what happens is it's not going to be a one and done. The immune system is always geared to remember. But what it remembers is pieces, and it's going to use whatever pieces it remembers, either from past viral infections or how you're reacting right now to just normal environment, and it can amplify. And sometimes it's an amplification by mistake. So sometimes what we're finding is certain viral infections can trigger, say, autoimmunity. And partly it's because you may be autoimmune prone and you've never had that, but there are certain genetics that are predisposed to it. And so what can happen is if you have sort of like certain things come in line, you may be seeing negative effects later on, well past the initial, whether infectious challenge or vaccine, because of cross reactivity. And that's the way the immune system actually works. It remembers, and then it tries to choose the best fit for what it sees at that time. And what we see as children, as teenagers, and how we react is very different than how somebody my age sees. It's going to rely more on the memory, and therefore some things don't fit as well, and you can be seeing sometimes effects that are not good. And that is something that I think we need to understand more. The problem is sometimes we just only look at, say SARS-CoV-2 and only how we react to that. But as a human being, we're always exposed, and that our immune system is doing what it can. And sometimes, in case of aging obesity, we see with SARS-CoV-2 an overreaction. What happens is that leads to even more problems rather than the virus itself. So sometimes the immune system is not geared to be as regulated. So things break down as we age, and the regulation breaks down. And that's that cytokine storm you hear about. But it also means that we're having to figure out at the end of the day, there could be you're reacting to the virus and you fight the virus, but if your immune system's too good, you can get toxicity. And then later on, there may be other things that trigger that reaction, not even the virus, but maybe other viruses, and that can cause problems as well. So we need, that those kinds of dynamics need to be looked at a little bit more carefully.
Got it. So then there is a related question. So first, there is a question from Paul Wolf as well, and that is what you're describing, is it like allergies, that some of us have allergies?
Right, and that's a fascinating concept, because the hygiene hypothesis is that we're too clean, and that's why our immune system's looking for something to react to that isn't dangerous, right? And so, in the past we'd have parasitic infections, lots of other things, and that keeps our immune system busy. But if it doesn't have anything, it becomes hyperreactive to ragweed pollen and things like that. So yes, allergies is another example of something that could be due to cross-reactivity to something that we've been exposed to and your immune system's just using it, or your immune system is just a hair trigger and it's just going to react to anything different. And then maybe other things based on lifestyle and what you're exposed to make you now more prone to these things. And so those are all issues that come into play.
Got it. And you are a PhD in this area. Disentangle one more thing for me, and that
Yeah,
is, on one end, we have folks who are responding with long COVID-like symptoms,
right,
long COVID in case of COVID and post-vaccine injury in the case of vaccine. But then there is a concept of vaccine antibody waning. And
right,
so on one end, the immune system just continues to bother someone. And on the other end, it just stops working or reduces working 4 or 5 months into it.
right.
What is the difference in these two type of behaviors? I
That's a
mean,
good
we
question.
know the clinical difference. What is the mechanistic difference?
Right. And that's a good question because it's complicated. Because what we're saying about waning depends on how we test or assess it, our assays, right? So we think it's waning because the ELI or the antibody test that we're using, we're not picking up as much. And we already have a problem because we already know there's 7 coronaviruses. 4 of them are endemic and cause the common cold, upper respiratory tract infections. 2 of those coronaviruses actually have a spike protein. That's to be a coronavirus, you have a spike protein. Have a spike protein that also binds ACE2. So that means there's going to be a lot of memory because everybody, pretty much the bulk of the population from a young age, has been repeatedly exposed to these other, what we call endemic coronaviruses. Well, your immune system is just going to see another virus and it's binding a similar kind of receptor. And so what's going to happen is sometimes that will cause some triggering. But also what's very important, and that's what that article was talking about, the immune system is also about control. You can't just keep everything going and it has to turn itself off. And this anti-idiotype response that we talk about is a way that the immune system regulates itself. It makes antibodies to the antibody. And that causes those antibodies then to go away, right? Because you don't always need those antibodies around. You're going to be exposed to other things. And that's the way that the immune system regulates itself. So part of the thing is when we look, if we look early, you'll see a response. But there is a reason that we don't have a vaccine to the common cold. There, as far as other than the changes that occurs, is because we already have a lot of responses. It's hard then to induce a new response. And so that could be another thing that's going on. It's going to be the kind of thing where we have to be careful when we say you don't have a response, because if you're just looking at the blood and you're looking for antibodies, you may see something, but it depends on your sensitivity and what you're looking for. But then there's a whole nother arm of the immune system called the T cell arm. And we're not testing for that because that's really hard. We test for T cells when we look for a TB response, tuberculin response. That's a T cell response. But for the most part, for most of the viruses we look at, whether it's hepatitis, HIV, or whatever, we're looking at antibody responses. But that's only one half of the arm. So it could be that we're missing that part, and there is something there. Because one thing we know, though, is as we get older, these immune cells can live as long as you do. And that means that response can live as long as you do. It's just waiting to get activated. Okay.
Got it. Thank you very much for this. So then another related question. We study in immunology that the memory cells
Mm-hmm.
can be near the site of infection, for example, lymph nodes or circulating or in the bone marrow as well. And
Mm-hmm.
if they are in the bone marrow, then they're going to be long lived.
Yep.
So imagine if somebody became long COVID because the memory cells of anti-idiotype memory cells
Mm-hmm.
went into the bone marrow and are living there and just continuously working.
Right.
How do we get rid of them? How do we control them?
That's a good question. We've had some interesting discussions with some of the other immunologists here at UC Davis. Um, it's almost like you almost have to get rid of them if they're going to be problematic. And getting rid of long-lived B cells or plasma cells is going to be difficult because, like you said, they're in the bone marrow. Some things will wane over time. So, for example, if you get immunized to tetanus, you need to get boosted every 5 to 10 years because it wanes, because your immune system is starting to react to other things and it pushes out the cells that it's not using that much, i.e. tetanus. That's why you have to get boosted. The problem with something like to a coronavirus, because they are going to be endemic, that means we're getting constantly exposed, even if we're not symptomatic. That means your immune system is going to be constantly triggered, even at a level you don't realize. It's going to be an issue because usually when we have an overreactive immune system, we give immunosuppression, steroids, whatever, and that blankets everything. We're going to have to start to maybe figure ways that we can target the cells that are deleterious, that may be causing, say, autoantibodies. And that's been the holy grail for other autoimmune diseases, whether it's lupus or rheumatoid arthritis. Unfortunately, right now we don't have a means for that. That's why we use just blanket immunosuppression or anti-inflammatory cytokines. And that comes at a cost, because if you do too much immunosuppression, then you're prone to infection or even cancer. So I think that we're going to have to figure ways that we can target more. I think the anti-idiot type theory gives you a mechanism, because if we now know what those antibodies are, we can make antibodies to those antibodies, or we can target those autoreactive B cells. But that's further down the road.
Got it. Got it. Thank you very much. So this definitely, as you were discussing before, research can be clinical or it can be mechanistic.
Right.
Clinically, we are observing patients who are becoming long COVID. Fortunately, it seems like over time they start becoming better, but there are relapses. Tell me this, do we have, from your point of view, do we have sufficient research in the basics of the issues that we are seeing, or are you seeing mostly clinical research?
Unfortunately, it's been almost dominated by clinical research, and you can see that in the publications. And I'd like to also point out the caveat that while long COVID seems to recover, it depends on what you're calling recovery. It's based on symptoms. There's just a paper published in Nature Medicine where they followed from the VA patients over a 1 year period, and they found even asymptomatic patients, that means they were infected but they weren't symptomatic, were more prone to heart conditions later on, as far as more at risk. So there is levels of, and there's actually it's been in the press too, where they're seeing even some brain involvement with brain effects, even with post-infection. So what we're saying as far as long COVID right now is pretty much a description of symptoms, but we really don't know what's causing those symptoms, and they may be cyclic in nature. But there may be underlying effects that makes people more at risk, i.e. for heart or neurologic conditions that are not really, because it's so new, haven't been really appreciated. And you may be asymptomatic, but still may be more at risk. And who knows, with continuous exposures, does that increase? These are all important questions. The critical thing is, if you're waiting for the clinical data to come out, because you're dealing with people getting infections at different times, different demographics, different vaccines, it becomes almost a quagmire of trying to make sense of what's really going on outside of things seem to be more descriptive. Basic science is where you actually can take things away, put things back, optimize, look over time, and a lifespan of a mouse is 2 years. So in a 2-year period, you can go all the way at every stage in development to understand on how an infection or immune perturbation or a vaccine has an effect. Those studies are not being done because, unfortunately, usually in most biomedical research, it's getting to the clinic is the hard part, and that's where you put all the research in. And then once it's in the clinic, then you let the clinical data speak, and then you can maybe look to optimize. The way these vaccines and the way the virus has been studied, it's been so fast that the basic science really hasn't been supported. And so we really need to go take a step backwards and be more proactive. Now that we know that there can be long-term effects of both infection and potentially the vaccine, we need to go back and invest into that. The other thing is, unfortunately, a lot of the studies to develop these drugs are by companies. And so access to either the reagents or the data is not going to be as free as within the academic community. So mobilizing these resources have to be done. It's being done for cancer. It just needs now to be done more for this kind of pandemic, given the fact that we're reliant on both these vaccines and we're reliant on what we know about the infection. So the majority of clinical studies, the preclinical studies, the basic science studies, have relied solely on, is this regimen protective to the virus? But they're not looking long term, right?
Mhm.
And so everything is more on, does the animal live or die, or is there lung pathology or not? But not like, okay, let's let this go now and go longer term. What happens with continuous? And then we could get some insights. Those studies need to be done.
Got it. And I actually have this question as well, that after the infection
Mhm.
or after the vaccine, what are the possible long-term outcomes that should be in the list of people who are researching them? So I don't want to spook anyone to say, all right,
Right, right,
3 years later we would all die. That sometimes people are saying. The
right,
question is, somebody got vaccinated or somebody had an infection.
right,
From an immune mechanisms point of view, what
right.
are the things that should be of concern from a research point of view for longer term?
So clearly, the virus itself gives you some insights, right? So what makes SARS-CoV-2 so different compared to, say, some of the other coronaviruses is it's got certain manifestations: cardiac, clotting, the olfactory, the nerve. These are things, even gastrointestinal. These are things that, if the virus can do that and have that pathology, that needs to be something that we're looking at, where even if you're not showing it acutely, could you be causing damage later on? And therefore, too, when you realize vaccines are not the virus, but they are a portion of the virus, if there's an immune component, which means that there's something that you're seeing protracted outside of, it may say, for example, if you get pneumonia, you get damage to the lung that's permanent, but it's a permanent damage, and that explains why you may have breathing issues later on. Versus if you have something that is immune mediated, that is something that could be progressive. So one thing that we could be looking at is, what are the symptoms of the virus itself, and can people be more at risk either with the vaccine or with the virus? Because keeping in mind, people, even when they're vaccinated, are being exposed to the virus, and there could be another trigger there. But then also looking at the preclinical models. So, for example, we know that antibodies to ACE2, which would be anti-idiot type antibodies, ACE2 is the receptor, you make antibodies to the spike protein, and then the spike protein that can exert antibodies, and it could be to ACE2. It's been documented that even for many years, that people with other kinds of connective tissue diseases or immunity can have anti-ACE2 antibodies. Now, whether they cause that or they're just correlatives is one thing. But one thing we know too is, when we understand the biology of ACE2, we also know that some mouse models show that mice that don't have ACE2, they knock it out, can have heart issues. And so that's telling you that, okay, something's going on. When you take this away, it has a problem. Now, if you make antibodies to it, like autoantibodies, that could do the same thing. And we could gives you an idea of what we need to look for. Now, the spike protein binds other things outside of ACE2 potentially, and that should also be looked for the vaccine. The virus itself can have other effects outside of the spike protein, right? And so those are things that need to be looked at. Finally, the formulation on how we give the vaccine. So the mRNA vaccines, it's RNA. It can exert immune effects on its own. The nanolipoprotein conjugation that it does to make it last longer has effects as well. So those are all different pieces that gives us ideas of what we need to be looking at, both short term and long term, and under different conditions. So, for
Got it.
example, we're
Thank you.
looking at effects on fat mice versus lean mice, old mice versus young mice. We can give the same immunotherapy drug to a young mouse with a tumor, and it's fine. We give it to an old genetically identical everything, and that animal will die from the therapy. And that's actually what we see sometimes in cancer patients, as far as how we treat an older person with cancer, but it's different than how we treat a younger person with the same type of cancer, because the immune system in the body reacts differently.
Fascinating. Thank you very much for this discussion. If you allow me, I want to loop in some of the comments from the users, Cool Beans here. And by the way, Cool Beans, I think we are the only group around COVID and COVID discussions who are very well versed with many of the immune mechanisms, many of the medical mechanisms, and we can go deeper and we can understand those things. So that is uh, a little matter of pride for us. So there is a question here from Bambi. Sorry, I want to go to Nipa's question first. So Nipa's question is: never taken yearly flu vaccine. Most in India haven't, did not feel the need to. Is it or now was it needed? So question of other vaccines in during this pandemic, should they be, not be? How do you see it?
Well, I mean, clearly you're dealing with the situation both at a personal level and at a societal level, right? Because normally prior to the pandemic, flu was a problem because it was affecting our hospitals and our elderly patients. It was a cause of morbidity. Now with the pandemic, that's almost supplanted flu as far as an issue. And actually, it's kind of interesting. What people were really worried about at our medical center and others was if when the flu season came, it was going to be a tsunami. In as much as you have both, you could get both, and people have been shown to get both, or it's going to just overwhelm our whole system. That didn't happen, partly probably because the masking and the lack of traveling restricted flu. We didn't have the flu outbreaks we normally did. Ultimately, it becomes a matter of what your algebra is or your calculus on what you're at risk for. Flu is going to be a problem among older people and those are at risk. And it's going to, anytime you get something that is a severe illness, and I mean, like, for example, if you have pneumonia, you're more at risk because it causes more damage each time. So if you can do a preventative treatment that will at least take care of that aspect, that's one. Now, we already know, too, the flu vaccines don't always work. It's based on a formulation. It varies every year. Everybody's immune system's different. So it's really going to be a matter on how at risk your population is, and therefore what you think you're going to be exposed to. We live in a country where we travel a lot, and therefore you're exposed a lot. I know I would get sick every time I go back and forth reviewing for the government, da da da. So those kinds of things put you more at risk versus maybe in other places where you're more staying local. You may not have that kind of exposure level, and you may not feel the need to be always vaccinated. I'm at a medical center, so we're always being exposed, and we're also putting patients potentially at risk, like cancer patients. So it behooves us to always be vaccinated. So it's just going to be a matter of, some of these vaccines are very, been used every year. They're very safe, and there's a long track record. Now's not the time to probably deviate from that. The question is, though, if you give them at the same time, do they counteract each other or they're not? Those are questions that we still need to understand too. People want the
Correct.
universal vaccines, and that can take a while.
Got it. Thank you very much. Uh, Chang says, Dr. Bean, I suffered pericarditis after second Pfizer jab, and 3 months later, I had a relapse of breast cancer. Carcinoma cells changed from triple negative to HER2 positive. Please discuss. So, any comment?
That's tricky because you're relying on what we would almost call, could be what we would call true unrelated events. In other words, the myocarditis that people are developing after the vaccine, it could stress your immune system, stress you, and therefore anytime you have stress, your immune system starts to break apart a little bit, and that means that maybe a cancer can come back, because a lot of times there's a dynamic equilibrium between your immune system keeping the cancer at bay, even if we don't see it. The change of the cancer phenotype is probably a little bit trickier because a lot of that may be depending on how they detected it in the first place. It's not an absolute. Whenever you see changes in a phenotype, it may be maybe the first one was wrong, the second one, we're just, I'd like to, you got to look at that a little bit more carefully. And usually the pathologist will deal with that.
Got it. And I think you have kind of answered this question as well. AFTF4 said, does Dr. Murphy think there's a mechanism for vaccines to cause cancer? Uh,
Yeah,
I don't know if it could cause cancer, but
no.
immune system could be overwhelmed, and that may happen from any.
Yeah, I don't think that, if anything, a lot of these vaccines activate the immune system. And so that may actually keep some cancer potentially at bay, believe it or not, because when you think about it, anytime you have when you get sick, you get fever, that's your immune system getting activated. And so there's a thinking that sometimes this is actually good because then the immune system may have missed that cancer before and they're getting activated, and some of that will now be directed to the cancer. And so that's how some of these same agents, the RNA is being used actually as a cancer active. It actually fights the cancer because it causes a non-specific activation, and we use some of those treatments already still. So I don't think that the vaccines would be negative in that sense.
That's very interesting, actually. Thank you very much. That vaccine is triggering the immune system, and so there is a rampant immune system, so it's going to try to take care of many, many things,
Yep.
including any newly budding cancer cells as well. Uh, I want to ask you about the TLRs and
Hmm.
the T cells. And so we talk about antibodies and B cells all the time. The T cell, their um, role with vaccine, role with infection, what should we understand from a basic mechanism point of view?
So the basic concept of the immune system is first it has to know there's danger. And this was a Nobel Prize winning concept in the sense of you can have your what we call the adaptive arm, your specific arm, your T cells and your B cells. But when you first get an infection or a virus, they're not going to see it. The first things that see it are going to be what we call your innate, which are your non-specific cells, your macrophages, your monocytes, your natural killer cells, your neutrophils. These are things that are not that specific, but if there's certain recognition receptors and it causes them to activate and release cytokines, and then this then causes then the B cells and the T cells to get activated. So it's basically a 1-2 punch. And so so whenever you get a vaccine, if you just injected a protein or anything into a person, you're not going to get much of a reaction. You have to give something we call an adjuvant or something to goose things along. The virus does it normally by itself, even though it's different. When it infects cells and the cells die, that causes these activating responses to get initiated, these toll receptor responses. And that's as a species, we've devised a way that we can recognize bacteria and viruses based on these, what we call pattern recognition receptors, these toll. And so when you get a vaccine, you may notice, when I got vaccinated, I felt it for 2 days. I was hammered. And so what that's telling me is that it was activating non-specifically, and that was then giving me a better immune response as far as specific response. Just like when you get a viral infection, you feel like crap, but you feel like crap because you're getting a non-specific, these cytokines are being released, and that's the purpose of that is also to then tell your specific immune cells, come here, let's do something. And so it's a good thing.
Got it. Got it. Thank you very much. This is a very fascinating question. I'm going to extend this question. So Eric Dog says, does Dr. Murphy have info about live attenuated vaccines with regard to cancer or other adverse effects? So if I can, with permission, Eric, if I can add to this as well. Now we have, especially in the West, we are looking mostly on the messenger RNA-based vaccines or adenovirus-based vaccine. But at least there are two more classes that are interesting. One is the inactivated virus vaccines, and the other one is the subprotein, the Novavax-like vaccines. How do you see them in their own right? Do you feel inactivated virus vaccine is better because it offers more epitope compared to spike, or messenger RNA based is better than adeno, or not, or they're all equal? How
No,
do you see as an immunologist?
yeah, it's complicated because clearly, and this is the earlier studies even with Jenner, with the cowpox, as far as to immunize for smallpox, attenuated or viral vaccines tend to elicit stronger responses because you're getting an actual viral infection. The problem is controlling that. They even, we had the flu attenuated for a while, and obviously the Salk and the Sabin smallpox polio vaccines. I mean, are different. One's attenuated, one isn't. It's tricky because if you're immunocompromised or if you're older, that is walking a tightrope with an attenuated because we're assuming that it's weak enough you're not going to get a full-blown infection, but that has happened. And so that's why it may depend on whether you're at, peak immune would be something like you're, 12 to 25. your immune system is rock solid, ready to go, you could handle it. But as you get older, the attenuated may be trickier. Similarly, too, each vaccine formulation, whether it's adenoviral, RNA, or whatever recombinant, is going to have pros and cons, and we need to understand that more. And we may have to tailor depending on what population. I think it's important to note when you're dealing with vaccines, the popular perception is, again, one size fits all. And it may be that we need to understand how the immune system is on, say, age 55 and up versus pregnant versus young. Your immune systems are very different. And so what may be an optimal vaccine for one population size or demographic may be different. Just like we don't give certain vaccines to young children because their immune system is not developed enough. And so those are things that we probably have to now take into consideration more rather than just one size fits all.
Got it. Thank you very much. So next question I want to ask is about the obesity and the inflammation and COVID. But before that, if I can ask a question from Bambi as well. So Bambi says, and Bambi is from UK, she's been with us for almost 2 years now. So if you only got a mildly sore arm and mild fatigue for 2 days post Pfizer vaccine, or I would say any vaccine, does that mean you haven't had a big enough immune response to vaccine and potentially less antibodies?
That's a good
And this
question.
is a very common question people
Right.
ask me all the
And
time.
it's a good question. And at first, I envy you for only getting a sore arm because, like I said, I was hammered. Um, no, it just means so when we're getting the sore arm and the systemic effects, some people even get fever and chills and things like that. That's the non-specific part. That's the toll thing that's being triggered right now. The specific arm, and it may be that you can be just as efficient. Just like, for example, you can get a great, people don't get sick at all with a tetanus shot for the most part, and you can get a rip-roaring response. So you can't really go by that. In fact, there's questions as far as if you have a really severe, like if you have a severe SARS-CoV-2, people were thinking, I've heard there were people saying, oh, getting the actual infection is better. Not necessarily, because what can happen too is if you get very sick or, your immune system sometimes can shut down a bit, it short circuits it. And so you really don't want a situation where you're very, very ill from the actual infection, because you may think you're getting a very strong response, but sometimes it actually does hamper that because of the non-specific component. And so I'd say right now, I wouldn't go by any indication on how bad your reaction is and how good your response is, because it's also not how much you get, but how sustained is it. The big issue we're having is, when do we get boosted? What is the formula for when the responses start to wane? And I think right now we need to understand that more rather than how strong the initial response is.
Got it. Thank you very much. I wish I could just keep talking with you about these things forever. So, one more question. The obesity, inflammation, vaccines, COVID, why is it that COVID impacts obese people more?
Yes.
What is going on there? What's the
So
mechanism?
obesity, unfortunately, I think the rate is 42% in the United States is considered obese, and that's a BMI, body mass index of over 30. That's not even overweight is 25, obese is 30, and it's growing. So obesity causes what we call a meta-inflammatory condition. It causes a lot of inflammation, and it also causes what we call inflammaging. It ages your immune system. Um, and so what happens is, at least with this virus, it can induce what we call a cytokine storm. Remember what I said, as you get older, your immune system changes. Things break down. Your regulation, the immune system is all about control. It's got to suppress and turn off, because otherwise your immune system starts attacking itself. In obesity, what can happen is this non-specific component that I told you, the toll response, and causes these cytokines that we see in cancer treatments. We also see it in other kinds of situations. It causes these cytokines like TNF and IL-6, these key cytokines, to get amplified. So if you have rheumatoid arthritis or Crohn's disease, a lot of times they're going to use blockade of these inflammatory cytokines to take care of the condition. Obesity heightens this. And so that's why it can be a real problem because of morbidity. So if your lungs, for example, are the primary target organ and you have a hyper response, then this inflammation actually causes more damage than good. It's meant to fight the infection. The problem is it's not regulated, and that's why we call it a storm. And so that's why some of the treatments we're using in COVID for the cytokine storm were used in autoimmunity and even in cancer treatments. We're just basically seeing that the same thing can work. And that's going to be an issue with obesity that makes you more at risk then, particularly with this virus. It's already been shown obesity is a negative prognostic indicator for many kinds of therapies and disease states. So we know that. And this virus has just highlighted that as being an issue. The problem is, too, it's not just obesity, aging also, because as we break down, inflammation increases. So it's basically a 1-2 punch. If you're, as we get older as a society, as we get more obese, then the immune system becomes more dysregulated. And then during an acute infection, it's going to become harder and harder to treat.
Very interesting. Thank you very much. And just going back to the previous vaccine discussion, there is a follow-up question that I think is very interesting. Les Smith says, is there a class of vaccines that are generally safer for people who have had immune-mediated neuro issues like GBS, especially if suspected of having previously triggered by a vaccine?
Yeah, that's a good question. These RNA vaccines are very new. I mean, they've been around in the sense we've tried them in cancer in a small population. It's unprecedented to try this in a large population to this extent. And then so many, there was such a rush to get it out because, frankly, it was needed. It's not known at this stage, for example, if you've had a myocarditis issue or even anaphylaxis. Some of these have been associated with anaphylaxis. What is your next course? And I think that's because we just don't really understand, because we're dealing with a very broad population, right? In other words, you're dealing with people of all different walks of life, ages, exposures, and it becomes very difficult to tease out what is a better formulation for who's at risk. Now, for example, if you develop myocarditis from the RNA vaccines, they haven't been noted as much for the adenoviral vaccines. That's been noted for more clotting events. So I think if you're getting a negative effect from one, that'd be the one you steer away from. But to make a general categorization, I think it's going to take a lot more data to figure out what are the risk factors initially that can trigger. And I think we need to understand that a bit more and understand long-term effects. And that's where the basic research has to come in, because it's going to be years and years if you're relying on clinical data.
Got it. Thank you very much. One more question before we go to, I want to go to aging as well. Kelly says, is there an immune-related reason, I would say, / mechanism, why someone would collapse, faint a few hours after a Pfizer vaccine?
How the vaccines work, even the HPV vaccine, the Gardasil, has been shown to cause fainting and in some people. The immune reaction could be to sort of like an anaphylactic kind of reaction, which means that there could be a cross-reactivity or something that is allowed. So when you get anaphylaxis, that means you have preformed antibodies that are an IgE for most anaphylaxis are ready to go. And that's why you see an immediate effect. That's why even with the RNA vaccines, they ask you to wait 25, half an hour just to make sure. And so it could be, and we don't understand why the fainting component comes in, because like I said, it's been associated with other vaccines as well. And it could be due to many things, as far as some immune, some due to even psychological. It could be many things all working at once, making you at risk. That would probably be why, if you see an immediate reaction, if there is an immune component, it's because of a cross-reactivity or anaphylactic reaction.
Got it. Thank you very much. So I have my questions, but there is another beautiful question. So Skyfrog says, what is the specific cause for obese being a problem or obesity being a problem? Number of fat cells, sugar level, metabolism, a combination, etc. What is it?
Basically, I would just say yes. You hit a lot of that. There's what we call the Western diet when we do our studies, which is high fat, high sugar versus just high fat, and they have different effects. Um, Definitely, we're trying to figure that out right now. Is it the adipocytes or the fat cells? It's not just when you have sugar; it's also going to be what we call your hyperglycemic. You have high fatty acid content. The metabolism changes. All these things contribute. And believe it or not, the microbiome, what's in your gut, has been shown to be affected with obesity, and that contributes. So all these things play a role in how obesity can be an issue. So we're looking at issues: is it the body fat? And there's actually a thinking now too. It's not just the body fat; it's how much muscle. So you could be actually obese, but you still have a significant amount of muscle, and that's actually sometimes a better indicator of a good response versus if you're sedentary and you're not as obese. So lean muscle mass seems to be playing a role as well as obesity. And it's been thought that there's many things like how it affects cancer. For example, it gives a lot of the nutrients that the cancer wants, and it comes at the expense of your normal cells. And so sometimes obesity too, the nutrients fuel the immune cells, and the immune cells then can get hyperactive. So those are all things that can contribute to the inflammatory issues of obesity. And it may be diet, it may be also the body fat, it may be how long you've been fat, because that can cause damage over time. All those things come into play.
Got it. Thank you very much. Very interesting question. This is a question that is very commonly asked as well. Carlos says, hi, doctor. Some doctors on Twitter have expressed concerns that repeated exposure to COVID will have a very negative impact on T cells. And I have heard the same messages with the vaccines as well, that, hey, you keep getting the boosters and the uh, T cells would be exhausted. And so, European Medical Agency, whatever their correct name is, they came out as well and they said, we are concerned about the immune system after multiple boosters. So, what would happen if there is repeated exposure either through infection or vaccine to the antigen?
That's a really good question because you can create the scenarios. Uh, the Nobel Prize in Medicine 2 years ago was actually for this cancer immunotherapy where they're reversing what we call exhausted T cells. And so anytime you get continuous antigen exposure, you can conceivably have these cells become less functional because the immune system doesn't want to always be turned on. And so one way it turns itself off is by inducing these breaks, as we call it, that makes the cells less responsive, all right, because it keeps them around. Because you can't keep running a 100-yard dash. If you keep running the 100-yard dash, you'll die, and your T cells will too. And so there's a fine line between how much to stimulate and how we can control for that. And so, yes, that is a possibility that you can actually, with repeated exposures, overwork it, especially as you get older, because as you get older, you have less of these cells to play with to begin with. And so you want to, keep them. And so for most of us have been exposed to EBV and CMV. That means we're infected and we're keeping the virus at bay. Chicken pox, that's why if you get older, you get shingles, because your immune system is always keeping the what we call opportunistic or latent viruses at bay, and you need them, because if you don't have them, then you can have really so one way to do that is some of these cells we have, they're not as functional, but they're there. And if we keep stimulating, we might exhaust them more. So that is a good point. It's just a matter of how much, and it may be depending on the person and what they have to work with. And it may be different for everybody. But it's a good question.
Fascinating, fascinating. I love, so generally, I love every part of medicine, neuro or immunology or cardiovascular, but immunology just fascinates me. These warriors in our body, and how do they behave and how do they control each other. So thank you very much for discussing all of this that I've been discussing for 2 years in 1 hour over here. One more question, very interesting question. Gold Country Russ says, why does vitamin D have such a big effect on immune response?
Yeah, vitamin D is being, God, when you think about it, we didn't even look at vitamin D, say, what 5, 10 years ago. And now we realize vitamin D has a profound effect on immune responses. The biology of vitamin D on immune responses depends on the cells you're looking at, but it definitely has an effect on both on every immune cell type, and it is important. As our population, I think, evolved where we're no longer outside. Most of us are in. Well, I have no windows here. I have a lamp with artificial UV, so I can simulate sunlight. It becomes there's vitamin D deficiency, and it's been shown now vitamin D has direct effects on the immune system, and it can be very important and anti-inflammatory as well as on the T cells. So it's very important that we look at this and appreciate this more. And I think you're going to see more and more of a push. You're already seeing it because we're measuring levels in people to see if they're deficient. But it definitely seems to be, and as we get older, it becomes even more important too as things start breaking down. So I think that that's something, I know Linus Pauling with vitamin C was the big story. I think vitamin D, people are realizing, especially given the way our society is now, we're not getting enough, and it definitely should be something that's taken seriously.
Got it. Thank you very much. So now a question from me. So Cool Beans, one of the questions here in the Cool Beans is kind of similar to mine as well. And that is, I have seen sometimes patients say that 2 years ago, I had this issue here in my abdomen or on my leg, and I was sick for 2, 3 months. And since the vaccine or since the infection, I just keep hurting in that area again. What is it that vaccine or infection of this severity can trigger or cause relapse of older issues? Why does that happen? Or is
Well,
that just psychological?
no, well, it's hard to know because when you have trauma or injury, you can have scarring and you can have inflammation and damage, right? So, and it can be whenever there's an area that was damaged, it's going to be something that's more susceptible to damage or feeling of damage later on, even if it's a neurologic condition. So, for example, if there's been a damage where you have had a prior injury, and pain is basically a neurologic feeling, and if you have something that somehow triggers neuro whatever, you're probably going to feel that more in that area. And not necessarily that it's causing the same exact manifestation, it's the feeling, or it could be causing some inflammation because of that. So it does make sense that you might see effects distally that are unrelated per se, but because we don't understand sometimes the neurologic components of some of the after effects, and there clearly are, that means it could be what you can be feeling is because of the prior damage being amplified before.
Got it. Thank you very much. And there is this very interesting question, and I'm going to add my question to this as well. So the question P. Lee J says, is there no way to produce more T cells as we age? And I'm going to add a comment here as well. For a long time, I have been thinking that why do we not donate our own tissue to ourselves in our younger age, put that in a tissue bank, and when we have become older, then we can get part of our own bone marrow or part of our own liver or pancreas and kind of grow those cells and then give them back to us. Is number one, this question, can we produce more T cells? And number two, is it possible to do auto donation?
So this has been an issue because of we never needed T cells as we aged, because when you think as a population, up to the age of antibiotics, the average life expectancy was 50 or 45, right? It's only now that we're living in our 70s and 80s. So our immune system has never evolved where we needed more T cells. And it was really because if you understand the limitation is your thymus, that's where you get your T cells from. And after, say, in your 20s, the thymus starts to atrophy because you didn't need any more. Because for the most part, as a species, we didn't travel a lot, right? So for the most part, you stayed in the area, and whatever you were exposed to, all you needed were the T cells that responded to that to live for as long as you did, and you're good to go. Is when we would go to new worlds or new countries, then all of a sudden you see a population getting wiped out because they couldn't respond to it. So it was really with the advent of, not the advent, it's when AIDS came around and bone marrow transplants for cancer, we realized that these people have no T cells and we got to get them back. And so that spurred on a whole bunch of different kinds of approaches to try to. Now we know that our thymus can work as we get older because we know people that have undergone bone marrow transplantation where their T cells are wiped out, they do repopulate, but it takes a long time. It can take years. So the problem is it can work. We're trying to figure out ways to actually goose that along. And there's really no way to do that right now. And it's not the level of bone marrow. That's not going to help you. It's your thymus. And you're not going to take out a piece of your thymus when you're an adolescent. I mean, that's just not going to happen. So what we're trying to find out, and there have been drugs looked at to cause the thymus to put out more T cells. And that's something that is being looked at. It's just going to be a matter of, will it be enough? And what is the extent? How many T cells do you need? So nobody really knows that. And so the problem is if we age, yes, the thymus stops producing. That's not good. But as I mentioned before, there's also the regulation is getting whacked out. And so then there's competition. So it's going to be a lot more complicated than just getting more T cells.
Got it. Thank you very much. And I'm going to ask a question, which is a very common, in my opinion, a myth, but there are actually a lot of serious discussions that I've seen, videos that I've seen, and that is a thymic massage causing more T cells. So there is a question related to that. Sita says, does thumping your chest, adult, make more T cells develop?
Well, I've never heard anything like that. Usually, any kind of manipulation on the outside is going to it's going to be difficult when you understand how cells within an organ work to actually cause any kind of stimulation at that level. The immune system, the reason the thymus shrinks is because the immune system has a system set up where it says you have enough T cells and you don't need any more. The only way we actually get the thymus to work is when actually you've gone through severe cancer chemotherapy or where you need a bone marrow transplant and there's no more T cells in the thymus. Okay, now we need more. Or with HIV, now we need more because they're gone. There's really no mechanism that I know outwardly that will cause the immune system to think it needs more because we're not even sure. It's quality, not quantity anyway. And so we're not even sure if that's even going to make a difference at this stage.
Got it. Thank you very much. M. Gregory says, can you reverse exhausted T cells? So is there any way to those energetic T cells who are sleeping somewhere to say, wake up, guys, work?
Yeah, and that's the cancer therapy. You may even be seeing commercials on TV for, where you see these late night commercials saying, we're, using your immune system. That's an anti-PD-1 or C3, but these are the what we call the checkpoint or the brakes. And they're companies, and these are one of the most rapidly growing cancer treatments in the world right now, is that they reverse the exhausted T cell. They get them to be more activated. So it's already there. It's already being approved and used in many kinds of cancer. We haven't used it in virus because we don't know at this stage what we need, right? So it's one thing as far as in a cancer patient, you see the tumor, you know what you got to react, and you know that this works. With viruses, we're not sure. It could be bad. It could be that getting them too activated, you may be more cytokine storm. So we're just not sure yet. But it can be reversed, and it is being done now.
Got it. Thank you very much. And I want to quickly take a little sidetracked discussion. So there are lots of comments about your desk, and people are saying that, hey, I love your desk. So over here, for example, I love his messy desk. And I wanted to share this, that number one, he's a distinguished professor. So that is a level above professor. That is what is called distinguished, or the top level of teaching is the distinguished professor. So of course, now you can see that here is a distinguished professor's desk. Number two, it is a fun story. When I went to meet him, Dr. Murphy, a few days ago, I think that was the beginning of this week. So we were talking about things in this office. And at one point, Dr. Murphy said, I have a study for you to read or an article for you to read. And there was a journal on the floor. And he picked it up and he said, in this journal here, this is an article. Take this and you can read it. And I was cracking up because that was just so much fun. There's just so much knowledge there. So once again,
the problem was, though, I got cited as a fire hazard at UC Davis. So I had to actually clean it. So I'm hoping this doesn't get back to haunt me. I got to clean my office again.
Okay. Got it. My apologies if we've been showing you.
It's fine. It's just clean the floor.
And so, of course, this is a sign of your genius. So, for the current situation, COVID,
Mhm.
the variant is changing and it is becoming Omicron, and it seems like everybody is getting it and probably even getting it multiple times. Is that a bad thing that is happening, that the virus is now, we are, majority of the people are getting exposed, the virus is more transmissible? Fortunately, it seems like less lethal, but let's just go with the more transmissibility in
Yeah.
terms of repeated exposures. Are we all at risk now from coronaviruses?
Well, I think, like I said, what we're hoping is that this SARS-CoV-2 will become like the endemic coronaviruses that we have now that give us the common cold. There was a theory put forth that the 1890 Russian flu that killed 1 million people was actually potentially due to one of those now harmless coronaviruses. So, when you're dealing with the viruses, you're dealing with a situation where there's an adaptation on both sides. And so, like for example, CMV, EBV, these are viruses that we all get and we control. And it's almost like a symbiotic relationship in a way, right? So the idea would be that SARS-CoV-2 will eventually become like the endemic coronaviruses, where it becomes no dangerous than the common cold. The problem is, we don't know if that's going to happen. And we also don't know how we can't treat all the coronaviruses the same, right? Because they may have different attributes that cause, when they do mutate, they may become more communicable or less deadly. But there's always a chance that a mutation can occur that can become just as deadly as before, but now it evades the immune system. And so those are things like when you think about, like with cancer, the problem is that when you get treated like with chemo or frontline therapy, the tumor does shrink. The problem is then when the tumor can evolve where it no longer responds to that treatment, and then it becomes resistant, and then you got to go to plan B. Um, the viruses, we can't assume. I mean, I think it's following that trajectory where as it becomes more, you get the herd immunity that we talk about, and you're getting the fact that the virus may be changing where it's becoming more acceptable as far as the risk. But at the same point, I always think it's good to think about best case, worst case, and always guard against the worst case, which means that, well, what if? Because clearly, when you look at the other coronaviruses like SARS, the original SARS, or MERS, which is even more deadly, you're dealing with a situation where it didn't change, all right? And so I think the communicability may be a good thing in the sense of it's forcing an adaptation on both sides, and maybe we'll come to an equilibrium where we might not even need vaccination anymore because, like with the other COVs that are endemic, we live with it. And it's just going to be a matter, you're only at risk if you have risk factors, right? Or, or obesity, aging later on, and then it still may be an issue.
Got it. Thank you very much. So before I ask a last few questions, I want to do a little uh, contest with the team as well. Cool Beans here. So Cool Beans, what part of the office, what do you like? I love that fat book behind on the off. So Dr. Murphy, I used to think that Guyton's and Gray's, these are big books, and I used to read them. They're somewhere over here. But you have a book right behind you, which could be probably two Gray's anatomies together.
Yeah,
So,
actually, that's a dictionary.
oh, that's the dictionary. Okay.
That's
So
a
beautiful
dictionary.
dictionary. Thank you,
Yeah.
ma'am. I would like to read that too.
Yeah.
Uh, there is another question which is, I think, is very interesting, and that is that please talk about long COVID as an autoimmune issue, particularly in people who already had autoimmune disease. I have caught COVID repeatedly very easily with long COVID each time.
Yeah. And that's where the idiotype theory comes into play. What could be going on is we know already, it's already been published since my commentary came out. A paper came out showing anti-ACE2 antibodies in patients after COVID, right? So we know that it's now no longer theory. It's a fact that you can get an anti-idiotype response following infection. Now we need to understand, can you also get it following vaccination? So those are studies that need to be done. Because it could be that it's something else outside of the spike. Unlikely, but it could be. Now, for an autoimmunity, there's papers that have come out recently showing a connectivity between EBV and MS. And so clearly, there is always been a strong viral autoimmunity connection. Thinking that, with any kind of autoimmunity, there are several things to keep in mind. Just like with cancer, there are risk factors, and some of it can be genetic. There can be a familial, a certain MHC, certain genes play a role in susceptibility, and you'll see it in your family history sometimes. And so that means you could be having a predisposition. There can be other things that go on too, as far as lifestyle and other risk factors. And then there can be a viral component or even a vaccination component that may be where the 1, 2, 3 is happening, and that's what's causing this. The problem with the vaccination component or the viral component is that you don't, especially with something that is so transmissible, is you could be still getting stimulated and not even be symptomatic. And that means your immune system is now being triggered again and again and again. And then it's just going to be a matter of, do you start to see those manifestations come up? And it could be that maybe you're immunosuppressed because of stress and things like that. And then you're seeing more of the manifestation of the autoimmunity, because stress can definitely trigger. So I think that there probably is an autoimmune component. It may not be the sole aspect, but it may be a contributor. And it's just going to be a matter of then teasing out, how do we control for that? All right. And then who's at risk? And then it's going to be a matter of then, what are the options? So, for example, it's difficult if you know you've had a negative effect of the vaccine or the infection, and then you're being asked to boost. Then you're going to say, am I more at risk? Well, theoretically, yes. And I think there needs to be an acknowledgement among the medical community that these are things that need to be taken into consideration. And then there has to be a calculus of cost-benefit ratio or options that may then make a decision on, for example, if you have lung issues, obviously the lethality of this virus outweighs, same thing with cancer. We would say, if you have stage 4 metastatic cancer, if you get autoimmunity from cancer treatment, some of these cancer immunotherapy treatments cause autoimmunity. Well, that's the price you'll pay to be alive. All right. So it's just going to be a matter of that kind of calculus. What makes vaccines so difficult is that you're giving it in a situation where you're preventing. Versus in a cancer treatment, you see it and it's going to happen. And so that's what makes it a little bit more difficult in that kind of calculus to figure out, am I putting people at risk? Am I at risk? And therefore, this outweighs that.
Got it. Thank you very much.
And also, the other thing is, what makes it also very difficult is what I'm worried about is with any of these kinds of situations like long COVID, or even with vaccine effects, is I'm worried that there can be also a psychological component, because it's on people's mind, and the mind is very powerful, that you have to be careful that where you're not, oh, I'm feeling it because I notice it more, and therefore it amplifies. So the psychosomatic component can come into play and amplify things, and that makes it very difficult too, both for the physician and the patient, because you're dealing with things that are subjective, how you feel, versus, like I said, with cancer, you see it. And so it becomes a more concrete kind of a thing that explains this. That's why the COVID effects and the vaccine effects, it's important to distinguish the short-term immediate effects. When people were seeing the myocarditis or the thrombolytic events, this was within a week of the vaccine. And so it was very clear to connect that. Long COVID and long vaccine effects are harder because there's other things that are happening at the same time, including, I know I get more sensitive to, if I have an ache and pain, to that area. And so that's something that has to be sometimes teased out.
Got it. Thank you. And this one last question, very interesting question. Augie says, thoughts on resolving eternal monocytes. And I can give a little bit of a background. There is a Dr. Bruce Patterson and Dr. Yo. They have done a research and their papers are published where they showed that some monocyte can continue to hang on to S1 part of the spike protein, and they just keep living. So now, do they continue to live, or they are phagocytosed and then the S1 just transfers to the new one? There may be multiple mechanisms. So, first question from a immunology point of view, are there things called eternal or long living monocytes? One, and number two, if they are there, is there a way to kind of stop them from being that way?
Well, I mean, clearly, if you ever see somebody with a tattoo and they've had it for 30 or 40 years, that's basically long-lived macrophages that have taken up the ink particles and they keep them there. And then if they do die, they get picked up again. So, clearly you can have long-lived what we call macrophages. Monocytes usually will turn over, but macrophages can be in the tissues and they can live for long periods of time. And then if the usually proteins get degraded. So when things don't get degraded, like when you're dealing with certain kind like silicon, like for asbestos, and or like I said, the tattoos, those things will hang around. But usually proteins get degraded. So it's not so much that you can have long-lived macrophages. You can. I'm more surprised the fact that you're going to still have the protein hang around, because proteins eventually are basically amino acids, and they get broken down because there's enzymes that do that continuously in a cell over periods of time. It's things that don't get digested that will hang around. So the spike protein component, I would think that you can have it, but I would think eventually it would degrade, and it doesn't matter how long the cells live.
Got it. So I promise that was the last question, but I'm seeing tons of other questions. One more interesting question. All are interesting questions, but this is Lorna says, Bambi Secret and myself have the same question. Is exposure to Omicron at all preventable, or all we can do is slow down how quickly people get infected? Are we all going to get it?
Well, I mean, I think part of it depends on what, I work in a laboratory where we have to have personal protection equipment when we're working with, say, blood products, for hepatitis. So we're gowned up, masked up, clothed up, all right? And so we don't get infected, all right? And so the bottom line is, I think that part of it's going to be depending on what's going on at the time in society. The masking clearly can show some protection. It give you protection. I mean, I work in a hospital where there's healthcare workers. There's reason that if you're in a hospital and you're going and there's COVID in there, you don't want to get it, and you're not getting it because you're wearing protection. It's just going to be a matter of then, because Omicron is so contagious, are we eventually going to get it because you're going to eventually be exposed and you're not wearing protection, and so you're eventually going to get it that way. It really is going to be depending on what kind of level of protection you want to give yourself. It's been said sometimes that masking is actually more protecting other people from you rather than you from other people at times, because you're actually not exuding out if you are infected. So I think that will be, but I think it's going to be, like I said, this may be like an endemic HCOV, in which people will be exposed. Hopefully, though, it won't have the same kind of pathogenicity that we're still seeing with Omicron and maybe some other variants.
Got it. Thank you very much. So before we close, I saw this comment, so I wanted to participate. Jocelyn said, Dad, I know you're watching. Happy birthday. I love you. So Jocelyn's dad, happy birthday to you and from all of us as well. And with this, Dr. Murphy, what a beautiful talk. I think we can continue to have these talks forever. And that was what was fascinating for me, that when I came and met you, we had similar discussions for a long time as well. So thank you very much for your generosity of time, for discussing lots of topics, and for your work, for your paper, for moving medicine forward. Thank you very much for doing that.
Thank you. It's my pleasure. And like I said, I just want to emphasize that I'm a researcher, not a physician. And so I know since that article came out, I've been getting lots of emails, and I've tried to respond to everybody. But I can't, unfortunately, it's a sort of uncharted territory. I'm trying to answer more of the basic immunology questions on how we can understand this. I think it's going to be dialogues like you're doing and with others that may be giving people that have real situations options, or at least a source to go to, because I think clearly that needs to also be taken care of as important as what we're doing too.
Awesome. So once again, thank you very much for being with us. Have a nice weekend. Cool Beans, you have a nice weekend as well. I will see you on Monday. Bye bye for now.
Thank you very much.